Welcome to my presentation on falls prevention for community dwelling seniors. Falls are the biggest cause of injury-related hospital admissions. 15% of the population in 2011 were over 65, and this is expected to double in 25 years. Falls can lead to a fear of falling, isolation and immobilization. Financial costs are anticipated to be $2 billion annually for falls. The research question for this intervention looks at the administration of multifactorial interventions and their impact upon falls. Multifactorial interventions are individually tailored to reduce identified risk factors and falls risks. Examples include exercise programs and medication reviews. To search for literature on this topic, various databases were used. One set of clinical guidelines, 3 systematic reviews, 2 randomized control trials, and a prospective cohort study were located and appraised using the AGREE-2 and CASP checklists. The evidence shows that multifactorial interventions reduce the rate of falls. In order to answer the research question, a falls clinic in a community rural setting will be implemented. The clinic will be an interdisciplinary service focusing on the assessment and management of clients who have fallen and have mobility and balance issues. It will be time limited up to 12 months and follow-up will be completed by community services. This shows the flow of clients through the clinic. They attend the clinic and a multifactorial assessment is completed. Interventions are identified and carried out. After 2 weeks, they return for a review visit with a therapy assistant and then are reviewed by the clinician at 3, 6, and 12 months and either discharged or reassessed. The stages of change model underpins this intervention. The contemplation stage would be the referral and consent to attend. The preparation stage would be the first attendance at the clinic. The action stage would describe the interventions being carried out, and the maintenance stage would be the long-term change in fall rate. Inclusion criteria includes rural community dwelling seniors with a history or at risk of falls, able to walk 3 meters with or without an aid. They consent to treatment and they score 24 out of 30 or higher on the MOCA. Exclusion criteria is cognitive impairment. Strengths of the intervention include that it is supported by the literature and clinical guidelines, there's policies in place to support the intervention, it's client-centered as it's tailored to individual needs, it's interdisciplinary, and it's low cost as the assessments are printed and not copyright. Limitations to the intervention include inconsistent current practice, differences in local rural contexts, so the intervention would need to be tailored for expansion, potential for resistance to change from staff, access to service for rural clients, and lack of adherence to recommendations. Thanks for listening, and I look forward to a discussion with you throughout the week.